Scott.
Good afternoon, my lady. Will you please call Laura Imrie?
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the
the
truth,
whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth. Thank you.
I hope you haven't been kept waiting too long.
No, thank you.
Good afternoon. May we have your full name, please?
My name is Laura Jane Emery.
And you are the clinical lead for NHS Scotland Assure and Antimicrobial Resistance and Healthcare Associated Infection Scotland, commonly known by the acronym ARHI.
That's correct.
And that's a position you've held since 2018.
Yes.
Could you please give us a little bit about your professional background and qualifications?
Yes. I qualified as a nurse in 1993. I then went into healthcare associated infection surveillance quite quickly in 1997, and then undertook a BSc in nursing with a specialist practitioner qualification in infection prevention and control. I then took up an infection control nurse job in the year 2000, and that's where my career in infection control really started. I completed a Master's in Infection Control at the University of the Highlands and Islands. I have held jobs in large health boards in Scotland, NHS Glasgow, NHS Lanarkshire as lead infection control nurses. And I came to Health Protection Scotland as a clinical lead for their healthcare associated surveillance programme. And being there a few years, I then became the interim lead consultant, and then I got my current post in 2018.
And so just a little bit about ARHI. So ARHI is a clinical service providing national expertise. In that circumstances, national within Scotland.
Yes.
For infection prevention and control, antimicrobial resistance and healthcare associated infection. It's part of NHS Scotland Assure, which is a directorate within NHS National Services Scotland. Could you just give us a little bit of relationship between ARHI and NHS Scotland Assure, please? So,
in 2020, NHS Scotland Assure was formed as a directorate within National Services Scotland, and it took, which was the HAI group in Health Protection Scotland and Health Facilities Scotland, and brought them together as one directorate within NSS. That came around after the Cabinet Secretary had been involved in the two children's hospitals, and there's currently an inquiry ongoing into the Scottish Hospitals inquiry around the buildings of hospitals. And it was concluded that facilities and infection control had to work more closely together. And to allow this to happen, it was felt that a national group team should be responsible for looking at the guidance and the process that was put in when we were building new hospitals or kind of any infrastructure builds to ensure that infection prevention and control and engineering science work together.
And is it working?
Yes, there's a number of projects we've supported. So ARHI Scotland has 6 priority programmes. One of them is clinical assurance, where we have infection control consultant nurses and some time of a consultant microbiologist who support what we call key stage assessment reviews. So KSARS is when we work with the board who's commissioning the build, and NHS Assure looks for the assurance that the design stage, the procurement stage, that they are meeting the guidance and that we are not progressing spending money and developing a build that would not meet the guidance for facilities or IPC. So, yeah, I think the feedback we've received from the board supported so far is that it takes a lot of resource. It's a new process, but it is supporting the board build hospitals and support the local infection control teams, the local facilities teams to do a lot of the translation of the guidance and put that into place when they're signing contracts as well.
And part of RHI will come a little bit later on about how it makes guidance, but part of RHI's role is to produce the National IPC Manual.
That's right.
That's right. And when was the National IPC Manual first brought in Scotland?
It was first published in 2012.
And obviously we've heard a lot about IPC guidance over the course of this inquiry. Did the Scottish IPC guidance in relation to COVID-19, and particularly about routes of transmission, use of masks, healthcare workers, did it follow the UK IPC cell guidance throughout the course of the pandemic, or did it differ at any point?
So the IPC guidance, that was a decision that was taken by NERVTAG, what infection control guidance were going to be in place.
Just in terms of whether there's been any diversion between Scottish guidance, because is it right that the Scottish specific guidance first came in October 2020?
Yes, we developed our own guidance in 2020, but I think it's quite important for the inquiry to understand when we developed guidance in 2020, how we got to the guidance that was already in the UK.
Well, I'm going to approach this chronologically, so maybe when it gets to October 2020, we'll touch upon it then, rather than taking things out of sequence, if that works. Just want to ask you a couple of very broad questions. On reflection, do you think that the IPC guidance, and when I talk about IPC guidance, I'm going to be focusing on routes of transmission, use of masks of healthcare workers primarily, and also the use of ventilation. Was it always correct as that guidance developed over the course of the pandemic?
Was it always correct?
Yes.
The mode of transmission?
The IPC's guidance about how it assessed what the mode of guidance was, about what masks should be used by healthcare workers. When you look back on the guidance, would you change anything?
I think it was an evolving situation. There was evidence that had to be reviewed continuously. We had a very small team of scientists, but they were working 7 days a week to try and keep on top of the evidence that was coming out. I think we did respond to evidence that was coming either from groups like NERVTAG, SAGE, the Advisory Committee for Dangerous Pathogens, international evidence. I think there was a constant review of the guidance, and there was changes made as we understood the pathogen and the transmission routes throughout the course of the pandemic.
So was the answer yes, as the guidance changed over the course of the pandemic at all times, we made the right changes at the right times?
Yes.
And so, I presume based on your answers that you're satisfied that it accurately reflected scientific understanding throughout the pandemic?
Yes.
Do you think it took a sufficiently cautious approach to the risk of airborne transmission or aerosol transmission when AGPs, aerosol generated procedures, are not being used?
I think the position we were in was very constrained by the dichotomy of describing something as droplet or airborne. My position today would probably align with that of the technical group of the World Health Organization, where, although they can't come to a consensus whether there's traditional airborne or droplet, they did come to the consensus that it would be more helpful to start to describe things as transmitting through the air. And in fact, RHI have completed a systematic literature review now on transmission routes that would also support a transmission through the air rather than describing things as droplet or airborne.
So it appears from that the fundamental starting point was that airborne droplet dichotomy. Is this where you're talking about that there's that boundary of size and everything underneath it is considered to be aerosol, everything over, I believe it's 5 micrometers, considered to be a droplet? Is that the genesis of this?
Yeah, I think on reflection, to describe by size isn't, for the people using the guidance, always an easy way to understand what you're asking them to do. I think going to there's transmission through the air of a pathogen and a risk-assessed approach of what environment you're in, what procedures are you doing, what is the pathogen, if you know, that there needs to be a more risk-based approach.
Okay, well, I'm going to come and look and see how some of those appeared in practice. If we can please have on screen INQ 000474276. It's page 50, paragraph 129. And this is the expert report provided by Professor Beggs to the inquiry. And it says that prior to the COVID-19 pandemic and up until 23rd of December 2021, when the WHO softened its stance, scientific consensus amongst the medical community, but not physicists and engineers, was that SARS-CoV-2 and influenza were not airborne. And then the classification of the WHO, and this was reflected in the WHO guidance on the ventilation of healthcare facilities. To what extent did the IPC guidance seek to follow the approach of the WHO?
We reviewed the WHO, any communication, any reports that they put out. We did review it. We reviewed other international evidence, CDC. And as we touched on earlier, Scotland moved to its own guidance in October 2020, and through the COVID nosocomial review group, we brought in international experts to join our meetings and to listen to the discussions and the challenges that we were having, and to offer us advice based on their experiences as well. So I think we did look widely to see what other people's experiences were, if we could learn anything from that. And that included the WHO, but much wider as well. As an emerging situation, you were looking to the literature that was published, but quite often by speaking to counterparts in other countries, you could get really good information that hadn't been published. So we were really, as an infectious control community, looking to share learning as quickly as possible.
But was there a desire to closely follow the WHO's guidance over the course of the pandemic?
No, I don't think there was a desire that we were sticking with the WHO regardless of what they said, no.
So just on this point here, so when the WHO softened its stance on airborne transmission of SARS-CoV-2, in your own mind, was there a connection between the WHO's change of stance towards airborne transmission in December 2021 and the change of the UK IPC guidance in early January 2022, which appears to have followed the WHO's change?
So again, I'm thinking back to what the guidance in Scotland said. In October 2020, in Scottish guidance, we had made FFP3 available for all pathways when we were doing AGPs. We made some changes. I think in 2022, there was actually a directorate level policy from the government to say in Scotland you could wear FFP3 if you'd done a personal assessment, and that was in our guidance. I'm not sure the IPC guidance, what change was made then.
But as far as you can remember, you were still on the IPC, UK IPC cell in January 2022, is that correct?
Yes.
So, given that we're talking about the relationship between the WHO and the UK IPC cell, was there a change in the IPC guidance within the United Kingdom that had been produced following the views of the UK IPC cell that arose because the WHO had changed its stance in December 2021?
I think there was a more robust approach taken to the hierarchy of controls around that time. And that might have been, the WHO might, the evidence that came out from WHO might have, been something that was considered. And I can't remember exactly why those changes were made at that time.
Okay, because The CMO technical report was published on 1st of December 2022. I believe that you were a reviewer of the IPC section of Chapter 10 about improvements in care of COVID. Is that right?
Yes.
And contained in the CMO technical report is the line that it is important that UK COVID-19 IPC guidance remained consistent with WHO recommendations. Why was it conceptually, why was it important that the UK's guidance remained consistent with the WHO recommendations?
I think it was important that as a minimum, the IPC guidance within the UK was aligned with what the World Health Organisation were saying. The World Health Organisation are the experts across the globe. They are the people that have studied infectious pathogens and how we control them their whole careers. So I think it is important that we trust that the minimum of what is required by the World Health Organisation we are consistently meeting.
So does that mean that you were never likely to go below a level of protection that the WHO were suggesting?
Yeah, I don't think we would ever went below what the World Health Organisation were suggesting.
But it was entirely open to the IPC cell to take the decision to offer additional protection to that sort of proposed by the WHO. Is that fair?
Not the IPC cell. So the IPC cell had no role, remit or authority to change the mode of transmission. And the mode of transmission that the controls were put in place for healthcare was the same mode of transmission that public health were putting public health measures in place for the general public, other key workers such as teachers, police, shopkeepers. So I don't think the IPC cell had the role, remit or authority to change what the mode of transmission was for a pathogen. When it's been decided internationally by international experts, and we have NERVTAG, ACDP, the senior clinicians, UXA. So I don't think the IPC cell were ever going to be the ones who changed how we controlled a pathogen.
That document come down now, thank you. But the UK IPC cell were the ones who were providing effectively their views on what the guidance should look like in terms of IPC guidance in the United Kingdom, isn't that right?
Yes, so that I think that's an important point. So NERVTAG, who are the governance advisory group to the government, and they have the structures around it, they done the assessment, and it was decided long before the IPC cell was set up that the guidance that we would use would be the pandemic influenza guidance. Now, this is the group that assesses new and emergency respiratory pathogens, so we would take counsel from them as to what the IPC, and then we would look at the evidence and write the IPC for healthcare guidance around that. The IPC cell was, if you like, an informal cell. It hadn't been set up as part of the pandemic structure for response. It was, if you like, the UK leads in each of the 4 countries saying, let's come together and try and put some guidance together rather than us all doing something separately. We reported in informally to the chief nursing officers, but it wasn't an advisory group the same as ACDP, NERVTAG, SAGE or the senior clinical group. So we didn't have the authority to start changing the mode of transmission. We can give consensus that the mode of transmission and the evidence that we are reviewing, both in our local epidemiology from the hospital, local teams, and the evidence that's published in international journals, we could then give a consensus to say, well, actually, we're seeing signs now that the controls that we've put in place around droplet are not working. But we would never be the ones who would have changed the mode of transmission.
The reason I'm asking the questions is to have an understanding of how you and how you thought that the IPC cell functioned and effectively what its role was within providing IPC guidance. So the fact that IPC cell was set up at all was as a result of a perceived gap in the response to the pandemic.
Yes.
So it was clearly doing something above and beyond what NERVTAG was doing.
Yes.
And it had the 4 public health bodies. So it had the IPC, specialty and specialisms across the United Kingdom, who are all members of it.
Yes.
And guidance was produced as a result of the consensus view of the IPC cell. Is that right?
So NERVTAG had made the decision that we
I'm
should
not
use...
talking about the specifics. I'm talking just in generally that IPC guidance, after the initial guidance had come through from the pre-pandemic that was based on the influenza, everything subsequent to that, any changes that may arise would have been following a consensus view expressed by the UK IPC cell. Is that right?
Yes, we make the guidance thereafter.
And so you would have been aware, and other members of the cell would have been aware, as far as you know, that you were the ones who were providing that core advice as to what the IPC guidance was going to look like.
Yes, in consultation with other organisations, groups, and feeding up. We didn't come to a consensus and then publish the guidance. So if there was changes to be made to the guidance, for instance, in Scotland, I would have taken that back if there was changes that I felt were going to affect the kind of principles of the guidance that would affect the Scottish guidance. That would have come back to the COVID nosocomial review group, which was a multi-agency, multidisciplinary group. We had consultants in public health, virologists, microbiologists, occupational physicians, workforce, Scottish Government, a wide variety of specialists and organisations. And those changes would have been discussed in depth at that group. That was our governance about if we accepted. So there was no discussions being made at an IPC cell and guidance. And likewise, other members of the IPC cell, whether they were Public Health England or NHS England, they would have went back to their, whatever their governance was around guidance for their country, and then brought that back to the IPC cell for discussion.
Yes, but given that you are a pan-UK body that was set up specifically to respond to the pandemic, that has effectively the lead knowledge of infection prevention and control in the United Kingdom, the consensus view of that body was always going to carry the most weight about what that guidance should look like, isn't that right?
Well, not necessarily. I mean, we have the specialty of infection prevention and control, but if I took something back to the Infection Control Doctors Network in Scotland or the Infection Control Nurses Network, and they said to me, that's never going to work, that's not practical, you can put that in your guidance, but we can't follow it, then that needs to be fed back, and then we need to address what's going into the guidance. So it's always in consultation. And all through the pandemic, there was a lot of consultation done with a lot of groups to understand what it meant. And it was a two-way conversation. So our Hive facilitated weekly meetings with our networks and the boards and then the special health boards. And the issues that they brought back were then considered at both CNRG and would feed back into the IPC cell. And that was things like the networks were feeding back that a low staff were wearing masks, and this was quite early on in the pandemic, that they discovered there was a lot of car sharing going on, and when they'd investigated staff clusters, it turned out that, you know, there were car sharing, and that was fed back, and then very quickly it went into the guidance and into policy about car sharing and masking.
But
So,
the road...
just, I missed the word, and so did the stenographer. Did you say cash sharing?
Car sharing.
Car sharing.
So I'm so sorry.
It's okay.
But that information would then have been fed back to the IPC cell. It wasn't that there was somebody, it wasn't there was another level who would have said, well, thank you very much for your advice, but we're going to do something different. Isn't the practical reality that the advice that came out of the IPC cell, which said this is what our advice is, was going to be followed across the United Kingdom?
Yes, but it didn't just come from the IPC cell members. What came out of the IPC cell was the result of wide consultation with CMOs, CNOs, NERVTAG, and each country had its own nosocomial group that was considering what the guidance changes would be. alongside the local EPI and other evidence.
Did anybody in any part of the United Kingdom ever change or not adopt a view that had been expressed as a result of consensus of the UK IPC cell, or were those always implemented?
No, I think there was some colleges that developed their own IPC guidance that might have been different.
Yes, but that's separate. I'm talking about when consensus advice had been provided by the UK IPC cell to the 4 different nations of the United Kingdom or any other senior clinicians group. Did anybody ever change it, or did they just say, we've taken that advice, thank you very much, and it was adopted?
Well, I think that was one of the things that led to Scotland developing their own guidance in October 2020. That some of the feedback we got from our service providers and stakeholders was around they wanted, more flexibility in using FFP3 across all pathways. There was some probable kind of local guidance that they felt the UK guidance couldn't provide, and therefore it left gaps for the Scottish workforce. So there was feedback like that. I think there was maybe a couple of occasions where the CNOs came back to ask for more information or to understand the evidence better.
Okay. Why was it that RHI was providing rapid reviews to the UK IPC cell?
We weren't providing them to the IPC cell.
Okay, but then why were they being looked at by the IPC cell?
Because there was nothing else available.
So does that mean that it was only RHI providing scientific advice that was considered by the IPC cell?
No. That means that very early on in the pandemic, both infection control professionals and clinicians were coming to RHI to say, I've seen this article print, online today, and it tells me that if you smoke, you're less likely to get COVID. And there it was published. It didn't feel right. There was a lot of information coming through quickly. That was one example. So RHI decided to do rapid reviews so that we could provide our Scottish stakeholders with a single place to go and see what's been published online. And again, we were doing a lot of pre-print publications. So normally if you have a publication in a peer-reviewed journal that's went through quality assurance, you're quite reassured that the methodologies used and the outcomes have been checked through peers. During the pandemic, in order to get intelligence out quickly, a lot of journals were doing what they called pre-print publications. So
we'll come to look at the methodology. I'm just trying to have an understanding about who was providing rapid reviews that have been looked at by the UK IPC cell. Because RHI were providing rapid reviews.
So RHI were providing rapid reviews to allow infection prevention and control specialists in Scotland to go to one place so that they could see what had been published and what the scientists had reviewed. We chose to publish them rather than just share them through emails so that they were easily accessible. We never intended that we would be the organisation that done rapid reviews for the next 2 years on IPC. We thought that an international body or UXA or, somebody would then take over looking at the international evidence that was out there. But nobody did, so we continued to do a rolling programme of rapid reviews. My reflection on that is that we filled a gap and we continued to do that. And maybe it would have been more beneficial if the IPC cell had had a separate subgroup, an evidence subgroup that maybe brought people from some of the other groups, SAGE, NERVTAG, and it was a UK group.
Different, would that include different, I'm groping for the word here, experts, thank you, of different, so physicists or engineers or anyone of that category, or would it just simply be IPC?
No, it would include, it would be a separate evidence group that could look at the evidence and then provide recommendations or conclusions for guidance development, the same way that we use the methods in the manuals now, albeit you would have to reduce some of the stages. But I think on reflection, that might have helped other UK nations feel that there was a sense of belonging, that it had been more of a collaboration, that they were more, it was more clear to them how the rapid reviews had been done, if that was the only thing that was available for the IPC cell to use.
Did you get a sense that other bodies did feel like that?
I think sometimes when you're working across the UK, it can be challenging if there's a piece of work just done by one country and the other countries are asked to adopt it. So maybe because they don't buy into it the same, because there's not been the same involvement, maybe because they don't understand, or they don't know the people who have done the rapid review, or they don't know the people that have done that bit of work. So there's maybe the confidence on how it's been done.
So how did it work? If you're a UK IPC cell member, were you emailed the latest RHI rapid review after it had become apparent that nobody else was doing these rapid reviews?
No. Our rapid reviews were never commissioned by the IPC cell. They were published every month, so they were readily available to anybody, members of the public, anybody that were there.
So it could be that a UK IPC cell member would arrive at the meeting and wouldn't have read the rapid review?
It may be.
In the absence of any member of the UK IPC cell not having read something like the RHI rapid review, how would they necessarily have had a sufficiently broad understanding of what the current scientific basis was for what the IPC guidance should be based on?
I don't feel I can comment on how others prepared themselves to come to IPC meetings.
And I want to then look at the methodology that was used by RHI and the basis of these rapid reviews. It's right to say that prior to the pandemic, RHI, or when you're creating the National Infection Prevention Control manual, then when you're producing guidance, that would take a period of a minimum of 6 months.
Yes.
And that would form a well-established process and a systematic literature review.
Yep.
And that's not something that was possible to do in the context of the pandemic.
No.
And so there was a different methodology that was applied.
That's right.
How did you choose the methodology that was used to make those rapid reviews? Is there an international, national standard, or?
No, there's no international or national standard for doing rapid reviews. Rapid reviews are normally done and we do rapid reviews routinely. If you're supporting an incident management team that's looking to control an outbreak, you might do a rapid review for them. So you're just quickly looking at the evidence. But they wouldn't then go on to be published as guidance. During the pandemic, the evidence was emerging so quickly that you would not have been able to do a systematic review. By the time you finished it, the evidence would have changed. You would have moved on to a different variant. So the methods that we chose to use for rapid review were really a cut down on the methods that we would do a systematic review, and removing some of the kind of more resource intense steps. Like normally in our systematic review, we would have 2 independent reviewers. We didn't have that. We had 2 reviewers, and they both reviewed different publications. We cut down the number.
When you're talking about 2 reviewers, but they reviewed different publications, so it wasn't that
there was there wasn't 2 independent reviewers going through the same as we would for a systematic. But the scientists were reviewing thousands of articles every week.
How much time did they spend doing that?
The full time, 7 days a week. They worked hours. We only had access to 4 scientists at the time.
Could you, without naming them, were you able to give broadly their qualifications for the role they're in to perform that task?
Yes. One of the scientists is actually a dentist who left dentistry and had developed kind of research interests around healthcare associated infection and came to RHI. And the other scientist is the principal scientist for RHI, who has been working in the area of healthcare infections for many years and has been kind of fundamental in the development of our methodologies and indeed our kind of updated methodologies that we published in 2024.
Do you have any, and this may be in reflection, do you have any concerns or thoughts about whether they were necessarily the best qualified people to perform those rapid reviews?
No, I don't have any concerns. They were following SIGN methodologies, although it was cut back. They are very experienced in both literature reviews, guidance, and working in healthcare and developing infection prevention and control. We have very robust structures when we're doing guidance. We publish, although we have reflected on some of the criticism around how open we were in the rapid reviews and which evidence we didn't consider. And as I said, the lead scientist has now developed a new methodology that we've piloted for the last 2 systematic reviews, which is more open, as in, we will provide our kind of considered judgment forms on. We'll publish them as well so that people get a better understanding of what evidence we reviewed, what messages we took from the evidence and how it became a recommendation, and so they can really follow through from the evidence you've reviewed through to what comes out in the guidance. So
is that a lesson learned from the experiences during the pandemic?
Yes, we fed back within our teams that a lot of the criticism we got, and some of it was on social media, some of it might have been coming in through questions, that people couldn't really follow where the guidance got the evidence from. So the rapid reviews, again, and another thing we reflected on was in some of the rapid reviews there is the word recommendation. And it wasn't which might have confused some people into thinking that the rapid reviews in themselves were guidance. So we've now made changes that in rapid reviews we'll never say that there's a recommendation from a rapid review, and there'll be more conclusions that we've drawn that would then go on to be considered for guidance. So there, I think the kind of 2 things we've changed.
Would you change the way, because when you read the rapid reviews, it doesn't appear in the way that you would for a systematic review that there is a kind of grading that's assigned to any of the studies or the conclusions. Doing a rapid review now, would you include that grading?
So that's part of what I think, if you have an IPC cell, then you need to resource that cell. So we had an IPC cell that brought together the kind of national leads and some of the staff within those teams.
Sorry, just at the moment, maybe I'm talking about 2 different things. At the moment, I'm trying to talk about those who are writing the RHI rapid reviews and how that document looks when it's finished.
Yes, so we didn't have the resource to do that. You're talking about the grading, and that's part of why a systematic review can take up to 6 months. We were turning these over, and as I said, the scientists were reviewing thousands of papers a week. So we were turning these over very quickly, and the limitations are all there. I think the lesson I would take for the future is if you need to do rapid reviews because you have another emerging pathogen and you don't have the evidence historically, then you should resource an evidence subgroup for IPC guidance that could then maybe take on some of that and have the grading and make it more clear and open for people to understand what the evidence has said.
Because that grading, would it also then help the readers to have an understanding of the strength of the assessment?
Yes.
And it would help prevent any risk of bias?
Yes.
And you said you're resourcing this evidential subgroup. What resources do you think it needs? How many bodies does it need?
Well, I think first we need to look at what are the groups that are set up for an emergency response when there is an infection prevention and control or a healthcare nosocomial element to it. And I think that came through in some of the lessons learned, both from CNRG and from the IPC cell, about that the structures should be in place. So similar to SAGE, NERVTAG, ACDP and other advisory groups. And the terms of reference should be agreed out with the group, rather than the group coming together and agreeing their terms of reference and asking CNOs and others, is that what you want us to do?
Is that because it would provide better transparency and openness by doing it that way? Is that the reason why you think it'd be a good idea? Or
I think it would be a good idea because when WHO or UXA announced that we have an epidemic, pandemic, a response required, that the structures are well understood and the roles and responsibilities are well understood of what groups are going to be asked to deliver.
So I want to then talk about the start of the pandemic, so moving away from how the rapid reviews were conducted and have a look about what the guidance actually said. You were talking about the NERVTAG guidance from, I believe it was around the 13th of March, and that was the pandemic influenza guidance that had been adapted.
Yes.
Is that correct? Why do you think at that point in time that in terms of the understanding of the route of transmission, so whether aerosols could be generated outside of AGPs, why do you think that that guidance was right at that time?
Sorry, I don't understand the question.
So I'll rephrase that. I phrased that very badly. So the NERVTAG guidance said that you should be using FFP3s because there could be a route of transmission via aerosols when there are AGPs. It didn't suggest using FFP3s when there wasn't use of AGPs. That's right, isn't it?
Yes.
And so effectively that's suggesting that there's no risk of aerosol transmission when when there's no AGP.
Yes.
And did you agree that that was a correct analysis based on science at the time?
Yes.
And why do you say that was?
That the droplet transmission
Yes.
historically involved the use of fluid-resistant surgical masks. It has been used for influenza outbreaks in healthcare for many years. I think the science behind it was that, not that you're not expelling aerosols, it's just that only when you were doing aerosol generating procedures was there enough expelled that would then be a risk.
And was that based on a presumption, or was that based on clear, unequivocal scientific evidence?
So I think there is lots of gaps even today in the evidence between droplet and airborne. And I'm sure you're aware, even the technical group at the WHO that published in April brought together experts from engineering, aerosol science, IPC, and I think the first thing that the chief scientist says is they were unable to agree on many of the key points. And I think today there's still not agreement from everybody around whether aerosols actually cause the transmission out with AGPs.
Can I take you to the CMO technical report? If we can go to INQ 000203933, it's at page 51. And it's the second substantive paragraph up from the bottom. It's just following on from footnote 214. It says, even transmission at close range was subject to prior assumptions, with the belief that the risk was posed by large droplets rather than more concentrated small aerosols, resulting in reduced focus on masks for protection against inhalation for people at close proximity. Do you agree with that analysis contained in the CMO technical report?
Yes.
Do you believe now that what's classified there as prior assumptions, are they a correct representation of the scientific position, or actually has the science today shown that those assumptions are wrong or potentially wrong?
I think there needs to be more research to truly understand, and I think that's why I would agree with the approach that WHO are taking to stop using the dichotomy of droplets and aerosols and move to a more risk-based assessment of the patient, the pathogen, the procedure and the environment, and the staff member as well. I don't find it helpful, and I have seen other witnesses suggest that we move the droplet size or the aerosol size, but I don't think that will make it less confusing.
Does it come down to, do you not need to protect against a route of transmission where there might be a risk that that pathogen will transmit via that route? Doesn't really matter about the science behind it. If a risk exists, you protect against it, particularly at the early stages of a pandemic.
So they start off, COVID-19 started off, as you know, as a disease of high consequence, and then it was reviewed by nerve tags and others to be downgraded. I think, yes, if you have an emerging pathogen, then we should take the highest precautions.
Do you think you did in the way that the IPC guidance was first looked at and first reviewed by the UK IPC cell? Whether or not nerve tag had originally provided it, did you not look at it and then think maybe we need to change this quite early on?
So there's still no evidence in healthcare settings that to recover viable viruses from aerosols. I mean, we've recovered RNA. There is always a risk that, yes, that can be a route of transmission, but you have to weigh that up against all the unintended consequences when you apply that precautionary principle.
I just want to look at the way that Health Protection Scotland dealt with aerosol generating procedures. If we can please go to INQ 000189647, and it's page 2. Did you have any involvement in creating this in your role within RHI?
No.
If we can please go to page 7. And it's that second page, sorry, that second paragraph. So, systematic review completed by Tran and colleagues. I think we heard from Professor Beggs that this is effectively the genesis of AGPs, that there was believed to be an increased risk of transmission of SARS. And says, that said, some of these procedures are considered to have a theoretical risk of aerolization and therefore are listed as AGPs based on the consensus of expert opinion, specifically induction of sputum. Is it not there that Health Protection Scotland, in the context of AGPs, are saying that you need to take a cautious approach to whether these AGPs do produce aerosols, yet even at the time that they recognised that aerosols could be produced by the human body outside AGPs, they weren't taking such a cautious approach?
Yeah. Yes, I think attributing risk to any single procedure is with any levels of certainty is very challenging, and we've seen that throughout the pandemic, where several independent AGP panels internationally looked to describe what an AGP was or what the risk was to a single procedure. And they found very challenging that the evidence was sometimes missing. And again, that's why I would say we should be moving towards allowing staff to make that assessment on the risks based on the procedure, the patient, the pathogen.
Yes, but I'm more talking about an approach, because if we just go slightly further down this document, it's the bottom paragraph. It says, although there was an absence of strong evidence to support some of the procedures listed as AGPs in this document, this does not mean that there is an absence of risk. A precautionary approach should be taken for all AGPs specified as potentially capable of generating infectious aerosols from patients suspected or known to have respiratory infections. So that was the view taken in March 2020. We've seen the paragraph above, which is talking about only theoretical risks of aerolisation. Would you agree that that is taking a cautious approach to AGPs in March 2020? That's what that document's doing.
Yes.
If you were to read that bottom paragraph again, and you were to replace AGPs with aerosol transmission by the human body outside AGPs, why wouldn't exactly the same paragraph apply? So if you were to read it, although there is an absence of strong evidence to support aerosol transmission outside of AGPs, this does not mean there's an absence of risk. A precautionary approach should be taken for aerosol transmission outside AGPs as potentially capable of generating infectious aerosols from patients suspected or known to have respiratory infections. Wasn't the same true?
No, because you're talking about transmission. So there's no evidence that in healthcare, there's no studies that have actually found viable virus in aerosols. Now, you're working on the theory, if you're doing AGPs, you're producing such a large amount of aerosols. So if you imagine an aerosol that's tiny in a droplet, it's 10 times its size, then the theory being that the inoculating dose, depending on what that is, the droplet will carry more of the virus. But if you're doing an AGP and you're generating lots of these small particles at the same time, then the risk is that you're generating, but you're saying that it's transmission.
I apologise, I'm not following the logic of that. So you're saying that there's no evidence that there's viable viruses in aerosols.
Sorry?
No, please.
In healthcare.
In healthcare, yes.
There's not been any studies that, so we've found RNA, we've found, but there is, now that doesn't mean that it's not happening, it's just that the number of studies that have done, we've still not got that evidence.
So, but again, I just want to go back to the logic of what you were saying, that there's no evidence in healthcare, there's no studies we've actually found viable virus in aerosols, yet you're saying that AGPs, because they produce such a large amount of aerosols, it was presumed that there was a risk of transmission?
So that would be the highest risk.
But isn't the logic of that you can have viable viruses in aerosols?
Yes, at that time when you're doing your AGP, but how long they last and how long they're viable for. Most of the studies that have shown staph transmission through aerosol generating procedures have been done and by the very nature that you're doing an aerosol generating procedure, you're very close, in very close proximity, and normally for an extended length of time. So again, we're going back to the procedure you're doing, the time you're spending. It's not the same as some of the other risks that may have been described.
But you're going...
Sorry, can I just... what you actually said was there's no evidence in healthcare that viruses are found in aerosols. Do I understand what you're really saying is there's no evidence in healthcare that viruses we need to worry about in sufficient quantity are found in aerosols. Is that what you're saying?
So the studies that have been done to look at aerosols and and I'm specifically talking about COVID-19, although they have recovered RNA, they have not recovered the kind of viable virus that could go on to transmit. So there's, and I'm not saying it doesn't happen, I'm saying there's a gap in the evidence.
But I'm trying to understand, let's leave aside COVID-19, because this is the view that was taken prior to the pandemic, isn't that right? About AGPs had a risk of transmission via aerosols, but non-AGPs didn't. That was the basic dichotomy, is that right?
And droplet.
Yeah. So there wasn't the strong evidence prior to the pandemic to support that there was transmission in aerosols.
No.
So why was there not an equivalent approach taken to the risk of transmission between AGPs and non-AGPs when aerosols might be produced by the human body? I'm struggling to understand the reason why you're drawing a distinction between the two, if they're not based on strong evidence either way.
I'm not sure I'm following.
I think we may be going around in circles.
The
Scott. I'm not sure I'm following questions or answers at the moment.
It was known about how to protect against the risk of aerosol transmission. That was the use of FFP3s. That's right?
Yes.
Along with all the other IPC measures, talking about the difference between droplet transmission and aerosol transmission is that you use FFP3s for aerosol transmission. Is that right?
Yes.
Yes. What would have been the harm at the start of the pandemic of using FFP3s if there wasn't any issues in relation to supply? Would there have been any concern about using FFP3s in those circumstances?
I don't think we were in a position to use FFP3s widely in the NHS. As you're aware, due to the UK legislation, to advise the use of FFP3 means that someone needs to have a face fit test. I know roughly in Scotland at the start of the pandemic there was around 7,000 staff members who had an up-to-date face fit test, which is a drop in the ocean, and I believe that the other UK countries would have been in a similar position. That was one of the considerations, and there was also, I'm assuming what you're talking about is applying a kind of precautionary principle. There was also supplies. If we wrote guidance as a precautionary principle to put everybody into FFP3, then not only would they had a large amount of our workforce that couldn't comply with the guidance and therefore couldn't come to work, we would also had high-risk areas where we had identified for our intensive care units, our high-risk pathways that might have been left without the FFP3s. They were probably two of the main constraints if you were looking at putting in a precautionary principle of an FFP3 without the evidence, but the evidence that, you know, we didn't have staff face fit tested, and there was at the beginning of the pandemic a very quick kind of rapid stock take of what stock we held and what was required, and from my understanding that would have made it very difficult to supply the FFP3s to the ITU units and the other areas we deemed high risk.
So were supply and practical considerations driving the advice that was being given?
No, it was a consideration if you were looking at the precautionary principle, which was discussed numerous times across the course of the pandemic. But at the beginning of the pandemic, I think that would have been two of the main considerations that would have been taken into account was the face-fit testing and the, what stocks were available from the pandemic stock.
Mr. Emery, you said some time ago that you should take the highest precautions, subject obviously to the considerations that you've just been outlining with masks. Face masks are just one aspect of taking the highest precautions. And I'm afraid at the moment what I don't follow, and I wonder if you can help me, is if when the pandemic starts, you don't know if it's aerosol or droplets. I appreciate you say that you wouldn't go there anymore, but at the time, that's where people were going, and it sounds as if people still aren't agreed as to whether it's droplet. Why don't the people issuing guidance and advice say, well, we don't know, too early in the pandemic for us to tell you if it's airborne or if it's droplet, as seemed to matter at the time, and therefore we suggest that you take the following precautions if you're able. It may be that you can't do the mask for the reasons you've given, although I think others might argue to the contrary, but surely there are other things that people could do, or do they all have unintended consequences and downsides?
I think what we need to, or what I certainly reflect on back at that time, was we were asking people to go to work and look after infectious patients, and with all the media attention and all the death that surrounded them, if you had said, well, we think you should wear an FFP3, and they would take that as the guidance, but actually we don't have the masks to give you, I think that would have been an unbearable anxiety for somebody going into a ward and looking after COVID.
I understand that. I'm just trying to move beyond masks for a moment.
Yes.
If you tell people it could be airborne, it could be droplet, then essentially you're telling people who know about these things, keep your distance when you can, try to avoid contact. When you do have contact, try to make sure you're wearing at least some kind of mask.
Yeah,
be careful in staff areas. Surely that kind of advice might help stop the spread?
No, I think that's really important. I think, unfortunately, at the beginning of the pandemic, we neither recognised pre-symptomatic carriage or asymptomatic carriage, and we didn't have the testing either. So if there was another pandemic tomorrow, would I wait to see if there was evidence of pre-symptomatic or asymptomatic? No. I think we would go into enhanced mask wearing straight away. Would we, and we did during the pandemic, because in Scotland from March we collected local epi data on all our amber and green, so not the COVID areas but the non-COVID areas, any areas where we had clusters, so unexpected clusters. We asked the local teams to go in and look at what are the lessons learned, did something go wrong? And there was themes that came through around, as you said, staff areas. I mean, some hospitals had airlines set up first-class lounges where they invited staff to have breaks and take their mask off, and they weren't doing anything contrary to the guidance, because at the time we didn't understand all the pre-symptomatic and asymptomatic. But even as we moved through the pandemic, we still seen a lot of the lessons that we learned from the cluster was staff were removing their masks and changing areas and duty rooms. And the Scottish Government, through CNRG, commissioned the University of Edinburgh to do some behavioural insights work with some of the medical and nursing staff, frontline staff, and they did, their findings were that the clinical teams viewed patients at a far higher risk than they did their colleagues, so their behaviours were adjusted when they were in a staff-only area. I think in hindsight we knew all that, and certainly if there was another similar pandemic, I think we would go in quite strong and say it's masking for everybody all the time. Yeah.
Is there any harm in including in guidance the fact that there might be some uncertainty about circumstances in which issues may arise?
I think you'd be raising anxiety within frontline without any evidence to do that.
Isn't that an assumption? Because there was anxiety raised by the way the guidance was applied anyway.
But there's no evidence to support you asking staff to wear or advising staff to wear PPE that they can neither access or they feel comfortable wearing.
Can I please show you? It's the WHO guidance of the 1st of December 2020, just as an example of what guidance can look like. In terms of INQ 000349135. It's at page 1, and we have, this is mask use, but I think it comes back to Ladyship's point about using things as a package of measures. And if we could just have a look at the first paragraph, it's at tab 25 of your bundle if you're following paper. The first tab of key points. Sorry, it's the paragraph underneath that. So it's that first tab where it's talking about use of masks as part of a comprehensive package. Even when it's used correctly, it's providing adequate protection or source control. So it's setting out there that it needs to be part of a comprehensive piece. And then if we can just go down, please, to page 4. And the WHO sets out in quite a lot of detail what the reviews have shown. If we just look under the guidance, it talks about the WHO's guidance on the type of respiratory protection is based on, sets out the basis for these, for their guidance. It sets out, sorry, if we can just go down a fraction, that, thank you. So it's talking there about all available evidence. It's discussing considerations that have been taken into account. And then it says that there's a majority of members. So the WHO has not shied away there of showing that the members who are creating this guidance have disagreed. And then it goes down to the bottom page, so the bottom paragraph on this page. And it says, in general, health workers have strong preferences about having the highest perceived protection possible and may place high value on the potential benefits of respirators in settings without AGPs. WHO recommends respirators primarily for settings where AGPs are performed. However, if health workers prefer them and are sufficiently available and cost is not an issue, they could also be used during care for COVID-19 patients in other settings. What would have been the harm of using a paragraph like that in the IPC guidance within the United Kingdom?
We did include that in our Scottish addendum, that a preference, an individual risk assessment could be done in an FFP3. And just last month we published our winter campaign, which also follows this. So we wrote out to our stakeholders to let them know that we've done a systematic review, but the stakeholder groups that we meet with to develop the guidance had asked that we did not change the guidance coming into winter time, but we've put out a position statement which is very similar to what WHO have said here, that you can do a personal risk assessment. So it's still directing you to the hierarchy of controls. So, you know, choose the environment, think about the procedure, the pathogen. This isn't just for COVID, it's winter preparedness for all respiratory viruses. But if you do all that and you still prefer to use an FFP3, then that is certainly included in the Scottish National Infection Prevention and Control Manual as it is now.
Yes, but I asked you earlier on, is there any harm in including the fact there might be uncertainty in which issues may arise? And your response was, I think you'd be raising anxiety within frontline without any evidence to do that.
So I don't think there was uncertainty. I think NERVTAG had reviewed the evidence and were quite confident that the influenza pandemic guidance should be used. I think there was, and still is, many studies that were done out with healthcare that have concluded that there may have been aerosol transmission. Now, whether or not these are transferable into healthcare, it's you're comparing community settings where you have absolutely no controls, so no masking, no IPC education, no distancing, no contact tracing, etc., to a very controlled healthcare environment that did have universal masking, that did have distancing and all of the other environmental controls. So the uncertainty was, there wasn't enough good evidence to say that we were uncertain.
So you're saying that there was sufficient certainty within the IPC guidance?
I don't think just within the IPC. I think, and that's why I'm referring back to NervTag and others, I don't think they said go with droplet and influenza pandemic guidance, but we're not certain about it. I think there was an understanding, and there is an understanding, that you need to be constantly reviewing the evidence, and that's why our National Infection Control Manual is a living document. We do constant updates to check if there's any evidence contained in it that is out of date, or if there's any new evidence that contradicts what's in it. I think there was always an intention that these groups would be reviewing the evidence on a recurring basis, alongside looking at the local epidemiology, so locally what's happening in the hospitals. And we followed quite closely both the clusters, so the unexpected cases that we had, plus our hospital onset, which all the UK countries come together to put the definitions together. And what we've seen across the whole pandemic through all variants was, as your community prevalence went up, 10 days later, hospital onset went up because people were coming in. And then we've seen the nosocomial infections going up as well. So, can
I just bring you back to the start of the pandemic? It's just one final question before I move on
to
the topic, my lady.
Well, I've got a question about the hierarchy of control, so...
I mean, entirely in your hands, naturally, my lady, if you wish to
ask it now. Is that convenient? I appreciate I'm a layperson. It's not my field of expertise. But I have serious difficulties with the hierarchy of controls. And I've been looking at the guidance on the RHI website. And it says it's a well-established protocol, which is why I'm commenting with diffidence as a layperson in this area. But it sets out, as I've heard earlier, the levels of protection, elimination, substitution, engineering controls, administrative controls, PPE. And on your website, it says PPE is seen as the least effective control measure and should be implemented only if the other 4 levels have been found or expected to be ineffective at removing risk. I find that really strange, that the use of PPE is not considered to be part of the measures, the package of measures that you would use to eliminate the virus. In other words, step 1.
Yeah. Yes. For a non-clinical person that's maybe had the background in IPC training and things, I can see that that's not as clear. I think what you're looking for is the highest level is not to have the pathogen in the clinical environment. So, you do telephone consultations, you don't bring people in to hospital that don't need hospital care, because we have had previously the UK response to things like swine flu was admit them into an infectious diseases unit, and we can contain them in there, whereas I think most IPC specialists would say, no, please don't bring them into hospital because you've introduced something. It's not that you would look at the hierarchy controls and just pick one. I think the hierarchy controls are really designed as well for organisations. So what we were trying to get across to our organisations was, if you're going to have a high-risk pathway, if you're going to have a ward where you're going to put all your COVID patients, then that ward should have everything. It shouldn't be overcrowded. It shouldn't, have poor ventilation or no ventilation, because if you're doing all this, then the risk does accumulate. And certainly within the COVID addendum, we advise local infection control teams, if they worked through the hierarchy of controls and they couldn't provide the environment, then they should be considering FFP3 in high risk areas. So I'll go back and look at that wording and speak to the team.
I was going to say, I'm challenging the orthodoxy. I'm afraid whenever I dislike something, I say someone's been on a course. And the hierarchy of controls looks to me like someone's been on a course. And they thought it seemed to be a good idea. And what I understand all that you said about, keep your distance, better ventilation, all makes perfect sense. But that is not taking into account that if you want to stop the spread of the infection and eliminate it, then if people are wearing appropriate PPE, surely that would be part of your elimination programme.
Yeah, and I will go back and look at it. You would still wear a mask, yes, but if for instance, you were going shopping, you couldn't eliminate it. You can't control the environment and everything, so we ask you to wear a mask. But I'll go back in the context that you've raised it.
Do you want to ask a question before we break? You sure?
Yes.
Well, I'll ask it and then I'll break for 10 past.
Okay.
Okay. Yep.
Is the position that when the IPC guidance had been produced by NERVTAG, in terms of the pandemic flu guidance that was then translated into become COVID-19 guidance, is it the position that effectively you were satisfied that there was no evidence that there was transmission via aerosol outside of AGPs, and so you would only change your position about whether FFP3 should be advised when there is a risk in terms of aerosols outside AGPs if there was strong evidence to suggest that that was a route of transmission?
So I think we were constantly reviewing all the intelligence.
But in terms of, was that the starting point?
I don't think anyone said this is the conditions that need to be met for us to say that FFP3 is required. It was much more a constant assessment rather than trying to achieve a certain position before you would change your stance. If NERVTAG or ACDP or the senior clinical team in the UK had came and said, we want the IPC guidance to reflect something different, then we would have written the guidance based on the evidence that they were shown. It wasn't the IPC that had a sole remit, role and authority to say what was going to be included in IPC guidance.
Very well. I hope you're warned that we take breaks, Ms Imbrie, and I shall return at 25 past. Mr Scott.
Ms Emery, I think you said in your evidence earlier on that if the pandemic started now that you would recommend widespread use of masks. Did I hear that correctly?
Yes.
Why would you do that now?
Probably the same reasons that we done it once we recognised pre-symptomatic and asymptomatic transmission.
Could you expand upon what that was?
That there was transmission events that when they were followed up, some of the subjects didn't develop any symptoms, but their households went on to develop symptoms. But they had tested positive first, indicating that they were the index case, or others who tested positive and then went on to develop symptoms a number of days later. And I think that's part of continuously reviewing the evidence to make sure that you are gathering as much intelligence to inform the guidance, that you don't just stick with these are the signs and symptoms and this is when you should wear a mask, that we used the epidemiology as well to advise the guidance.
Okay, so I think you opened the answer was there were transmission events. Is that what it boils down to? So there's now evidence of transmission events?
For establishing that an asymptomatic or somebody, up until that point, globally, it was understood that in order for transmission to occur, you would be having to display symptoms.
So when you say universal masks, do you mean outside healthcare or within healthcare?
I think if we have a similar situation everywhere, as I explained earlier, the community prevalence had a direct effect on the infections that both came into hospital and were transmitted in hospital. So if we want to control the nosocomial infections, then we are really highly reliant on the community controls that are put in place.
Okay. I just want to ask briefly about December 2020, and there was an IPC cell minute meeting on the 22nd of December that you attended, and there was a discussion there about whether the understanding of aerosol transmission had changed, and there was no change to the guidance. But following that, there was an email sent round by Lisa Ritchie that was asking for people's views about whether that consensus should change. That's right?
Yes.
If we could please go to INQ 000348370. And this is your email in response to that request, which was, please can any of the members let us know if they wish to recommend the use of FFP3s in the high-risk pathway. That's right?
Yes.
And it was the consensus had been based on the rapid review that there was currently insufficient evidence to change precautions. You set out rationale there, and then it's the bottom of we currently see on the page. There is no clear evidence of airborne transmission.
Yes.
And then if we just go over the page, please. It says there is a larger evidence base for the assessment, which also includes prospective sampling. I think that's what you were talking about earlier on, about that there hadn't been any air samples that had found viable viruses, even though they had found viruses. They weren't necessarily viable. Is that correct?
I'm not sure all of what I'm referring to there, but yes, it's to say that that's...
Because it's the middle line of that bottom paragraph. It says, this evidence base is in line with the SAGE position, which states that the evidence that aerosol transmission is significant compared to other routes is not sufficiently strong to recommend that respirators are used in locations other than high-risk clinical areas where aerosol-generating procedures take place. And at that point in time, you're saying that the Scottish had produced their own guidance, and that was in October 2020?
Yes.
And what was the difference between the Scottish guidance and the UK guidance at that time?
And that time, you could choose to wear FFP3 if you were doing an AGP in any pathway.
And why was it that Scotland had made that decision?
I think that it was feedback from stakeholders that staff felt, so testing, kind of universal testing and things hadn't yet been implemented. And certainly we didn't have the kind of near point testing that allowed staff to test somebody. We were doing a lot of testing before people come into hospital and then giving them advice to stay at home and protection and not to have contact before they come in so that they could get into a green pathway. And if the stakeholders fed back to us that staff felt if they were doing an AGP, even in a green pathway, they would like to be able to choose to wear an FFP3. And that was then put into the Scottish addendum.
Okay. And that was taken up following those views of the healthcare workers?
Yeah, it was part of our kind of comms between the NHS boards.
And is that very much in line with what the WHO's guidance had been on the 1st of December, which is, given that healthcare workers want that high level of protection, and if there's no issues with supply, then there's no reason why they shouldn't be able to use them?
I think it goes some way towards that. It's probably later on, before the individual personal risk review assessment was put into the guidance, that allowed staff even in non-AGP areas to choose to wear FFP3, which I don't think that ever made it to the UK guidance, as far as I can remember.
Because it doesn't appear in your email of this 23rd of December that you are suggesting here, and tell me if I'm unfairly categorising, that actually at that point in time that there could have been, should it have been wished, a change made to the IPC guidance which would have allowed healthcare workers to wear an FFP3 mask should they wish to do so.
Sorry, which part of the email are you?
Well, I'm saying it doesn't appear in the email. I think you wrote the email. It doesn't appear that you say, well, actually, this is what the WHO have suggested. Scotland's taken a slightly different view because we've been listening to our healthcare workers, and so maybe that's something that we could do if we don't think there's any downsides to it. That doesn't seem to appear in the email. That's what I'm asking. Is that an unfair categorisation of this email?
I'm not sure what you're saying doesn't appear in the email. The use of FFP3s throughout, or?
The use of FFP3s in when someone's doing an AGP in any pathway. The way you changed
the way we had it in Scotland. Yeah. So the IPC cell were fully briefed and understood what the differences were within Scotland guidance and why we made those decisions.
If we can just scroll down on this document, please. So that second paragraph under paragraph 2 is, in essence, we'd be changing the high-risk event from AGP to a COVID patient. And the line above that is, in the absence of supporting evidence, a clear understanding of the justification is required in order to communicate the risks that exist to staff in these areas that are not present in the other acute pathways. Again, it doesn't appear that you're letting everybody else, the other members of the IPC cell, following a discussion in which PHE and others had said maybe we should look to change the guidance. You don't seem to be saying there, well, actually, do you know what the WHO on the 1st of December has said? If there's no issues, then let healthcare workers use FFP3s if it makes them feel safer. Is there a reason why not?
This was an email back to the IPC cell. All the discussions have been around that, so I wouldn't be recapping why we're having the discussions in my email. I think there's a general understanding that the people that they email, the audience, are aware of the WHO's, if I'm understanding.
Right, I'm going to move on to a different topic and talk about ventilation. Do you think more priority should have been given to ventilation and air filtration in the IPC guidance?
There was separate technical groups that were looking at ventilation, who were probably more qualified to look at ventilation, including our engineering colleagues.
Right, so how are you working with them to have an understanding about the role that ventilation played in terms of what the IPC guidance should be within healthcare settings?
Within Scotland, Scottish Government commissioned Health Facilities Scotland to look at the impact of ventilation, and the microbiologist from our high was involved in that group, as was the nurse consultant that leads infection control in the built environment. So they were feeding in the kind of clinical interpretations and aspects, and heavily reliant on our engineering and facilities colleagues to pull together. But within Scotland, Scottish Government led on the kind of ventilation review for healthcare settings.
Well, Professor Susan Hopkins was asked, and she said that she thought that air filtration hadn't been given sufficient priority in the IPC guidance. Do you agree with that or not?
Yeah, I don't think it was an area that we really put any kind of guidance around. I think traditionally ventilation guidance is through the health technical groups, which there is UK and then Scotland kind of put their slant on it and call it the kind of Scottish technical group. So the ventilation guidance traditionally has not been written by infection control, but on our COVID nosocomial review group, we did have architects and engineers and facilities. So there was those discussions happening and probably being led through a different group rather than the infection prevention and control guidance.
Were there the same discussions taking place in Scotland as there were within the UK IPC cell, or were these discussions about ventilation only taking place in Scotland?
I was having discussions about ventilation within the CNRG, which was ultimately our kind of nosocomial governance route for discussing the IPC guidance. I don't think the IPC cell had a membership that would have allowed in-depth discussion around ventilation.
But if ventilation was a part of the IPC guidance, and you had to make sure that there was sufficient ventilation, because I think it was well recognised that there was a risk of aerosol transmission in poorly ventilated places. Isn't that right at that time?
Overcrowded and poorly ventilated.
Yes. So clearly the IPC guidance about the risk of aerosol transmission had to take into account the ventilation that was in place in these facilities. Is that right?
So we raised that ventilation was a risk to IPC, but during a pandemic, there was probably very little that could be done about the ventilation that we have in healthcare, and I think that's a reflection that we have, and certainly through the work of NHS Scotland Assure, are considering the ventilation, the guidance that we currently have, and the evidence around whether that's sufficient or whether it needs to be improved. And people talk about ventilation opening a window. That's not really ventilation. You've got to consider how your air comes in, how it goes out, your air changes, your air filtration, your pressures. So that is certainly not an area that the IPC cell would have tackled.
But if the IPC cell was having to consider the possibility of the transmission of aerosols, and it can happen in poorly ventilated and overcrowded places, but the view had been taken that it wasn't going to happen in a healthcare setting, how did the IPC cell know when they're considering whether to change the guidance about what was good ventilation? What was the measure about where the boundary was between what was overcrowded and poorly ventilated and where actually there wasn't a risk?
So there's technical guidance that describes what's good ventilation in healthcare settings.
But that was created prior to the pandemic.
But it's still a standard that will tell you your air changes and where you should be using HEPA filtration and things. I think it's widely understood that if it's not in technical guidance that you should have HEPA filtration, there won't be HEPA filtration in a design plan for a hospital. And indeed, a lot of the assessments we do, our hospitals don't even achieve the air changes that are in the technical guidance, either because they were built prior to the technical guidance or they are failing to achieve. But I do not think that was the role of infection prevention and control guidance to look at ventilation. And I don't think any member of the group felt that we were qualified to comment on the ventilation. What we did do is highlight to organisations that if they were looking after COVID-19 patients, they needed to take all this into consideration. And taking on board my lady's comments about the hierarchy of control, that was why it was in the hierarchy of control, so that organisations took that responsibility to appreciate that they needed to look at their facilities and consult their engineers and their facilities team.
So,
Can I just say, just before I get a flood of emails from health and safety specialists, my challenge as a layperson, and I emphasise that again, was to the utility of the hierarchy controls in the healthcare setting.
Absolutely.
Yeah.
Absolutely.
As long as everybody understands.
but again, if they're being provided, if hospitals, healthcare settings are being provided IPC guidance, how are they meant to know, particularly if parts of their hospital, parts of their facility are falling below the technical standards? How are they meant to know whether there is sufficient ventilation in order to prevent there being a risk of aerosol in a non-AGP setting? Because that doesn't seem to have been given to them about where the boundary lies.
So each board trust will have a director of facilities who has a legal responsibility for the health and safety aspects of a building and for compliance with building standards for healthcare, which there are many of them. And they'll set out within an ITU, you should have 10 air changes, whether you should have negative or positive pressure depending on the patient population that you're looking after, your hemato-oncology units, what their specialist ventilation will be, theatres. They'll understand in general wards what their mechanical ventilation is. They should, for ID units and things, understand their airflows as well. So this is not a local infection control team or a national infection control team to set the guidance or the standards for ventilation. The infection control team recognise where the risks are within a healthcare setting. Now, that might be the air, it might be water, but you don't expect an infection control nurse to be able to go and examine the pipes and to say, that that's been set up in the wrong way. They can say if this and this and this occurs, then there's a risk from the environment and this is how we address it. But it wouldn't be the IPC cell that would be looking at ventilation guidance.
Well, did the IPC cell, given you were just talking there about infection prevention nurses saying if this and this occurs, then there's a risk from the environment, was there any guidance given to facilities managers to say, in this and this situation, actually, there is now a risk of transmission, and so you need to make sure you're taking steps to prevent that occurring? Was anything like that provided alongside the guidance, either in Scotland or UK-wide?
Yes. As part of the CNRG, as I said, we had Health Facilities Scotland, we had Director of Facilities. The hierarchy of control set out that if you had a high-risk area, that you need to do an assessment of overcrowding, of ventilation, and if you couldn't meet them, then it had to go through a risk register, and it should sit as a corporate risk so that your executive team are fully aware that they didn't have a facility that was deemed safe. So all of these things were put into the guidance, and they were discussed widely, certainly within the Scottish CNRG group as well. The infection, as I said previous, RHI had weekly meetings with the infection control managers, nurses and doctors networks. All the boards were represented, and they would go back and speak about the guidance, about the challenges. They learned from each other, from the boards, if they had put anything in place or where their challenges had been. So there was full discussions around the environment.
Okay. What lessons have been learned from your perspective or from RHI's perspective about the creation, the dissemination, the changes made to IPC guidance in the context of the pandemic?
Well, I touched on the actual structure and the remit role and kind of authority into how that fits into an emergency plan, a preparedness plan. CNRG did do quite a lengthy lessons learned around the experiences of CNRG. The IPC cell also done a debrief of some of the lessons learned. I'd say some of the main challenges was around publication, and there was a lot of red tape. So there was sometimes decisions made to respond to either international evidence or feedback we'd received, and the guidance was agreed, updated, and we in Scotland were updating our weekly meetings. Sometimes we had them twice weekly, but then there was a delay of a week or 10 days before it actually got published because of all the red tape it to go through to be published in the Public Health England website.
Any recommendations you think the inquiry should consider?
Around the IPC cell.
Ideally, yes.
I think, as I said before, it would be beneficial for there to be an established remit role, as there is with other advisory groups, and maybe not just for pandemics and emergency situations, but for UK response to anything. We've got 2 recent examples of measles and mpox where guidance has went out and the IPC specialists have went back to the people that wrote the guidance to ask for some things to be changed or included. So we're still not integrated into that response. So I would like to see that we were at the table having the discussions rather than, as we were with the COVID, told that this is the guidance you should use, and then we go away and write it.
Those are the questions.
Thank you, Mr. Scott. Ms. Polachek, who's that away?
Good afternoon. I ask questions. Oh, sorry. I now will ask you questions on behalf of clinically vulnerable families. And you've discussed in quite a lot of detail the IPC measures in relation to healthcare staff, and I just have 2 specific questions about the IPC measures for patients who are particularly vulnerable to the effect of COVID-19. And the first is, did AHI at any time give or consider giving guidance on the IPC measures for clinically vulnerable or clinically extremely vulnerable patients in healthcare, such as those patients wearing FFP3 or FFP2 masks, or the use of portable air filtration around those patients?
Thank you. High Scotland were never involved in the development of the guidance around shielding or clinical vulnerable. What we did do is work with the clinical cell to identify some of the vulnerable groups and the measures that we should take in the green pathways to try and ensure that they could access healthcare in an environment where people had been tested prior to coming in, that we were reducing the exposure. And that was both for clinically vulnerable people and people that required like a general anaesthetic, because it was understood at the time that if someone was COVID positive and they had the general anaesthetic, then that was very high risk. So there was a protective pathway that we worked with the clinical cell to advise. There was not the recommendations, as far as I'm aware, from any group for FFP2 or 3 to be worn.
Thank you. Given the particular risks to the clinically vulnerable and clinically extremely vulnerable patients who are accessing healthcare, including through green pathways because of nosocomial spread, do you agree it was common sense that there should have been some additional measures for their protection?
Yes, I think possibly there could have been more done in these areas. I think it was a real challenge. It is a real challenge for patients to wear masks, and I could see how that would be quite worrying if you're a clinically vulnerable person in a room and somebody else is not even wearing a fluid-resistant mask. So, yes, there were real challenges around that. An FFP3 would be very difficult for somebody who maybe has other clinical conditions to wear. An FFP2 may be slightly more comfortable. However, we are governed by the health and safety legislation, and therefore we were not allowed to recommend FFP2 for either patients or staff.
Thank you. Madam, those are my questions.
Thank you very much. Mr. Simblett, he's just behind you, but if you could make sure your answers go to the microphone.
Yes. Okay.
Thank you.
Thank you, Milady. Ms Imrie, I'm asking questions on behalf of the COVID Airborne Transmission Alliance, or CATA. And CATA was specifically name-checked by Mr Bowie KC in his opening address when he said that you and our High Scotland would not shrink from the important issues that they raise. So I hope you'll be able to help us with the two topics I'm going to ask about. The first topic is the IPC guidance and PPE supply. Now, that's been extensively covered with Mr Scott this afternoon, and we've the inquiry's heard various evidence about PPE supply and IPC guidance. In your statement, you say that RHI had no concerns on the 1st of March 2020 over PPE supply. Is the reason that you had no concerns because you expected the infection and prevention control guidance to reflect the state of supply?
Thank you for your question. No, that's not the reason. In the statement, the question that I was answering was, prior to the pandemic, did we have any concerns about the PPE? Prior to the pandemic, our understanding was there was a pandemic stock that was held UK-wide, and rightly or wrongly, we assumed that that stock would be sufficient for whatever controls were put in place.
Were you aware of minutes from the IPC cell around that time? Not, in fairness, not at meetings at which you attended, but you'd have got the minutes, where it was observed that guidance on changes to PPE could affect PPE supplies, and that was to be noted as an issue going forward. Was that a consideration for either you or the other members of the cell?
If you say I wasn't at the meeting, I won't be aware of the discussions, but what I am aware of is very late at night telephoning ITU units to find out how many FFP3s they were going to need for the following day, depending on how many COVID patients they had admitted, how many times they had to prone them, counting it up, going back to national procurement. So there was a real issue that maybe prior to March we weren't aware of what the stock was held and what we had. We certainly weren't aware of how many members of staff had had a recent face fit test. And one of the reflections that we've had in NSS, as myself and RHI working with national procurement, have put a proposal up to the Scottish Government that we should have mandatory face fit testing, and it should be an agreed period for all boards, and that national procurement should have access to all of these tests so that they hold the stock that is required for service rather than what is thought to be required.
Thank you. I'm going to move to a different topic now, and you're very politely answering, looking at me when you answer, but I think it is important that you speak into the microphone, so I shan't mind if you do that. This is about the IPC minutes of a meeting on 12th of May 2021, which you were at, and I'm going to ask for the first page of that to be put on the screen. It's INQ 000398232, and the first page of that. Have we missed a zero? Oh, I think, yes, the witness has it, but we haven't got it. Right, I see. Thank you.
I've got a document headed 12th of May 2021.
Yes, good, lovely, thank you. Now it's on mine, thank you. As long as my lady and the witness have it, then I suppose that should do. The first thing to observe is this is a meeting at which you are in attendance. There's a number of people whose names are redacted. I'm not going to ask you to say who they are. That's why they've been redacted. And generally, it's understood that the people have their names redacted if they're at depending on levels of seniority and so on. So those are relatively junior people in this meeting. Now, I want there were some discussions about revisions to the IPC guidance and the fact that Public Health England was feeling, unable to sign off on the cell's proposals. If we can turn to the next page, please, where that discussion begins at the bottom of the page. Can you see it on your screen, Ms Imrie?
Hey, it's just come up now.
Thank you. Yeah, so and then we see feedback from. We see in the middle of the page there, the PHE wish to move this issue forward. It would be inappropriate to provide a decision statement prior to decision from evidence review. And the next, page 3, please. I think it's the feedback. No, it is still here. So it is still this page. Sorry, it says, there you are, it's your comment. So I'd highlighted it on mine, what you said was LI suggested all nations involved, as well as PHE, should be involved in the work raising concerns in relation to the cell losing independence and work driven by the PHE agenda only. One organisation should not have the final say on UK IPC guidance. So the first question about that is, what did you mean about the cell losing its independence?
I'm just looking at the notes above. I think this is around the respiratory evidence panel review
Yes.
that Public Health England came to present, where they presented a number of studies that had been done out with healthcare that showed there may have been transmission, but not in healthcare where we had the controls. I'm not really
Well,
sure.
Can I summarise it this way? Was it that Public Health England was taking the view that the cell's consensus view, or perhaps more accurately what ARHI was saying, that COVID-19 was spread by the droplet route of transmission, that was the cell's position, that was being undermined by these studies, and you didn't want that idea, as it were, to catch on?
No, that's not accurate. Public Health England done a review. They excluded healthcare settings, and then they came in with recommendations that we should consider putting more controls into healthcare settings. I think the discussions that took place were around Public Health England providing a separate statement, which we agreed with. And the point was, up until then, we had done everything by consensus. And we'd been quite open in our consensus when we'd fed up to the CNOs or the senior clinical team, that we might not have had full agreement, but this was consensus we agreed. And I think what I'm saying here is we can't have one organisation leading the IPC cell. There wasn't that remit for one organisation.
So did you regard consensus as being more important than accurate science?
They weren't presenting accurate science to show healthcare transmission. They actually excluded healthcare studies when they done their review. And so it might have been more appropriate for them to increase controls in the community where the studies were conducted rather than in healthcare.
All right. And now something that I hope you'll be able to agree with. Since, as your last sentence there records, you believed one organisation should not have the final say on UK IPC guidance, do you consider that discussions about guidance and PPE measures should have involved stakeholder organisations, such as CATA?
So within Scotland, we had CNRG, which was multi-organisational, multidisciplinary. Through CNRG, we also took any recommendations and changes to guidance to the Scottish Government senior workforce, which was represented with unions and staff side representatives. So we did have full consultation. We also met all our networks on a weekly basis.
So do you agree with my question then? Do you think it should involve stakeholder organisations?
I'm not agreeing that it should be CATA. I'm agreeing that we should have a good consultation process that allows many people to feed in their challenges and how they would implement the guidance. Unfortunately, when we do consultation, we can't do consultation with every party that has an interest. We try and now, and certainly our reflections are that we will try and demonstrate how the evidence is reviewed and put into guidance in a much more open and transparent way that allows people with an invested interest in it to understand how the guidance came about.
All right. Well, those are my questions. Thank you.
Thank you, Mr. Simblett. Ms Stone, who's there?
Thank you, Milady. Good afternoon, Ms Inry. I ask questions on behalf of COVID-bereaved Families for Justice UK. Can I take you back, please, to I have a couple of areas which relate to the overarching topic of aerosol transmission and its impact on IPC guidance. The first of those is liaison with the Chief Medical Officer in Scotland, Professor Smith. For context, would you agree that during the course of 2020, the evidence in respect of aerosol transmission developed, and you were aware of that?
Developed, as in we were learning more about the pathogen?
Yeah. So there was emerging evidence which tended to suggest that aerosol transmission was taking place.
In healthcare, that was not the evidence that we were seeing. It was close range.
Well, I think in your evidence today, this afternoon, you referred, for example, to a report from the CDC beginning of October 2020, which identified circumstances in which airborne transmission appeared to have occurred. Do you remember that report?
Not familiar. Do you know what report? Was it WHO or CDC?
It was a report by the CDC in the USA, which I think you made reference to earlier in your evidence in relation to airborne transmission.
I'm sorry, I'm not.
There was also in July 2020, for example, WHO acknowledged that airborne transmission could not be ruled out. Do you recall that?
I think there was the WHO around the AGPs, and when you're in the very beginning of a pandemic, you can't rule anything out, and I think that's why it's so important that you do continue to review the evidence, both for controls for staff but also for patients.
In his evidence, I'll move to the question, Professor Smith told the inquiry, Milady, for your note, should you need it, it's the day 11, 25th September, and it's pages 35 to 46. But Professor Smith said that he had concerns about the possibility of aerosol transmission and in relation to the WHO's messaging in the earlier stages of the pandemic, or at least by summer 2020. Did you know about that evidence?
I wasn't aware of Professor Smith's concerns.
No. Well, that was you've anticipated my question, which was that whether you or RHI were ever made aware, whether directly or indirectly, of those concerns on Professor Smith's behalf.
No, I wasn't made aware of his concerns, no.
What lines of communication, please, existed between RHI and the Scottish Chief Medical Officer?
There was a few meetings where RHI would present around the IPC guidance. Public Health Scotland held a weekly IMT, which was attended by Sir Professor Smith and other members of CMOD, alongside the Chief Nursing Officer's Directorate as well, and other directors within Scottish Government, where there was the situation assessment given, and the IPC RHI had an agenda at the weekly meeting to discuss any changes or what the guidance was.
So would you have expected to have been made aware of those concerns on Professor Smith's part?
Yes. Also, there was a number of occasions where the IPC guidance went up through the senior clinical team, which was all of the CMOs, CNOs, and discussed there around the healthcare controls. So,
in your view, did you consider the lines of communication between RHI on the one hand, the Chief Medical Officer on the other, to be adequate? Or could your work have been assisted by greater engagement with the Chief Medical Officer, or indeed direct engagement with him?
I think communication can always be improved, and it certainly could have been improved during this emergency situation. People were working 7 days a week. People were working, crazy hours, and sometimes you would find that a decision had been made late at night and you were catching up. It wasn't your normal kind of lines of communication, so I would, yes, say that we do need to improve both internally within our devolved country, but also wider than that, our communication lines.
Can I move to ask you a little more, please, about the position as at the end of December, or as at December 2020? You were asked a few questions about this by Mr. Scott earlier. We know from your statement, Ms. Imrie, that in 2020 there were 3,389 nosocomial infections with COVID identified. Would you agree that the level of nosocomial infection of COVID-19 was of itself evidence tending to suggest that IPC measures were inadequate and not preventing transmission in healthcare settings?
Yeah, so I think during that time that was 2.6% of all the positive COVIDs were nosocomial. So I think that gives you, it demonstrates how community transmission directly influenced what was happening in hospital and the controls within the community. Because as community prevalence went up, and that happened for many reasons, that some of the measures, the public health measures, were eased off. Schools went back. We've seen different peaks, and 10 days later, you've seen people not coming into hospital because they needed treatment for COVID, that they were an incidental finding. Sorry.
No. Understand the point. I think you've made it that hospital infection tended to go hand in hand with levels in the community. But the question's slightly different, which is to say, do you accept that the levels of nosocomial infection of COVID in 2020 indicated that IPC measures weren't working? Do you agree with that?
Yeah, it indicates that there was onward transmission. So if you have onward transmission, then the field, and that's why we've done the kind of lessons learned with the local teams to try and understand. And some of that comes down to some hospitals were unable to put in the distancing. We didn't have, in December 2020, we were only starting to roll out the testing. So as I spoke earlier about pre-symptomatic, people might have been put in a room and then developed symptoms thereafter.
Was it known by December 2020 that nosocomial infection was at concerning levels in Scotland and throughout the UK?
Was it known what the nosocomial levels were? Did
you consider that nosocomial infection as at December 2020 was a matter of concern?
I think healthcare-associated infection is always a concern. The difficulty here was the epicentre for this outbreak was out with the healthcare, and it was very difficult to put for the infection control teams working locally, very difficult for them to put controls in.
Well, you've got to work with what you can control in the hospital, is that correct?
Yeah.
And one of those things would be the masks that healthcare workers are wearing, for example. Do you agree?
Yes.
And you've agreed, I think, earlier in your evidence that FFP3 masks are a primary means of protecting against aerosol transmission. Would you agree with that?
Yes.
And so, as at December 2020, notwithstanding the levels of nosocomial infection that you were aware of, and the evidence that there was at least a risk of aerosol transmission, the UK IPC cell maintained its existing position on FFP3s and didn't recommend wider use. Is that right?
Yes.
Can you explain why there was a reluctance on the part of the UK IPC cell to depart from earlier guidance and recommend that wider use of FFP3 masks, despite those factors, i.e. nosocomial infection plus emerging evidence about aerosol transmission?
So the use of FFP3 masks would have had no impact whatsoever in nosocomial infections. So most of the nosocomial, where it was patient-to-patient transmission, was about the environment, so that we'd have beds that are too close together, that we have waiting rooms that are jam-packed full, that we didn't have testing at that time, so you were putting people in. And recorded frequently in the CNRG notes are discussions around patients being unwilling to wear masks. So an FFP3 may have reduced occupational exposure and transmission, but I don't think there might have been some improvement, but I don't think that would be the main factor in reducing nosocomial. I think it was about testing and accommodation.
But it would be a factor, wouldn't it? Because it would have the potential effect of, well, it would have the effect of protecting, providing greater protection for healthcare workers. Firstly, you've already explained that. It's the primary mitigation measure against aerial transmission. But it would have also had a potential impact on nosocomial infection, wouldn't it?
That wouldn't be where I would focus, reducing nosocomial transmission.
Do you consider that too high a threshold was imposed by the UK IPC cell for evidence of aerosol transmission and changing IPC guidance as a result?
I don't know that we imposed a threshold. As I said earlier, there wasn't a criteria that we were waiting to reach. We reviewed the local epi data, the intelligence that we were getting elsewhere, and we had those discussions with other groups, international experts as well.
I think earlier in your evidence, when you were talking about early in the pandemic, you said there wasn't enough good evidence to say we were uncertain. That wasn't the position by December 2020, was it? It was clear that there was evidence suggesting aerosol transmission.
I don't know. It was clear that there was evidence suggesting aerosol transmission. I think, again, the position that I would say now is it is constraining to talk about aerosol or droplet. I think there was certainly a lot of evidence where we didn't have distancing or the consistent and correct use of PPE, that there was transmission, or where we had patients who were too close together or who were housed in the same room as somebody, that there was certainly evidence of transmission.
I'm afraid we're going to have to leave it there, Ms. Stone. I'm really sorry. It's not your fault.
I only have one question, my lady, but I'm in your hands.
All right.
I'm grateful. Final, Ms Imrie, do you now agree that the precautionary approach ought to have led to the wider recommendation of FFP3 masks, at least by late 2020, as that evidence grew?
No, I don't think we should go to a blanket approach. I think we should look at a risk-assessed approach, taking into account all the different factors. And that is what we're having discussions with our stakeholders since we've done the systematic literature review. But we're acknowledging that we need to probably do a lot of education and develop resources to allow people to do those risk assessments.
Going back to the time, shouldn't the precautionary approach have led to a recommendation, except it's not a blanket approach, but a recommendation for wider use of FFP3 masks?
I think, given all the reasons that I gave earlier, that was why we didn't go to recommendation, that the evidence was weak to say that you would reduce the risk, and it's not a control you put in place for the kind of nosocomial. I think there's other things we could have focused on.
Define final.
My apologies.
I'll let you.
Thank you.
Ms Mitchell, that way, Ms Imrie.
I'm obliged, my lady. I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved. I was looking at RHI's remit, and it says it was to provide evidence-based guidance and expert advice on infection and prevention and control to reduce healthcare associated infections. So obviously very important for the Scottish COVID bereaved. The first thing I want to ask you about is that collection of evidence and consultation process that RHI takes part in. It's the evidence of the of the Scottish COVID bereaved that there was a significant disconnect between guidance on what was to happen and, in fact, what was actually happening within hospitals in relation to infection control. For example, the use of PPE. Would it have been a sensible idea to include patients and families to be part of the consultation group to capture this type of information?
I think there could have been strategies explored to try and gather patient and family experience. And I do think that is a lesson that many have taken on, not just IPC, but access to hospitals and things. So yes, it could have been considered, and it may have helped give some of the intelligence that we required to truly understand, as you say, what's in the guidance and what was happening in reality.
And also, as a result of that, another experience was that nurses were being, it's the experience of the Scottish Code bereaved, that nurses were being asked to work in wards where they had not been briefed on, for example, cleaning or nursing protocols. Again, is this the sort of information that RHI should have been or would have been able to capture had they looked for it in that way?
Each of the NHS boards in Scotland have an infection control team and an HAI executive lead that look at, if you like, compliance. I mean, cleaning and protocols for infectious patients have been in the National Infection Control Manual since 2012. So that's quite disappointing that was your experience. And I'll certainly take that on board and take it back to the guidance development teams as well.
But would that have been a helpful experience for RHI to have captured at the time to have assisted?
I do agree. If we had had some sort of process in place to gather people's experience, and not just the patients, but the carers. And I think that's not just from an IPC point of view, but there's obviously been a lot of discussion around the psychological effects and things like that. So I do think that there could have been more done to try and capture some of that experience.
Moving on, a lot has been asked of you already about droplet and transmission, etc., and the Scottish Code bereaved were allowed an opportunity to ask you about the criticism in that regard. I wonder if Milady might allow me to ask a question that is pertinent to it, but I don't think the answer has been given yet, which my question would be this. I posit it to my lady first so she can see if she's interested. The question was about criticism about acting too slowly in relation to droplet and transmission, etc. And we've heard from my learned friend, counsel to the inquiry, he posited the view that it was the World Health Organization that caused the change, and I think the witness resisted that as a reason. And what I don't think we've come to is actually what was the tipping point. If it wasn't the World Health Organization and it wasn't the wealth of information that was coming before RHI to say aerosol is a real problem, what was it that made RHI change its mind?
Everyone's pushing their luck today, aren't they, Ms. Mitchell? All right, you may ask it.
Sorry.
What was the tipping point?
What was the tipping point for RHI to say, OK, we're now going to consider that aerosols are an issue in hospital settings?
At what period are you referring to?
When the guidance was changed.
The guidance on
when RHI took the view, when it changed from just talking about in hospital settings droplets to we now accept that aerosols are now an issue too.
So we've done a systematic literature review on transmission, not just aerosol and droplet, but it's our transmission-based precautions literature review that's been published online. I think we are looking not just at COVID, we're looking at all respiratory viruses, and we are now agreeing, if you like, with what the technical group in WHO are saying, is around that it's not helpful to describe it as airborne.
No, I appreciate that, and I don't want to go into that again.
I don't know what part of the guidance or when you're referring to the change.
I think I shall just leave it there because I don't think it's going to assist my lady in any event. Moving on, many of the Scottish COVID bereaved families suffered losses of their loved ones through nosocomial infection, as you will know. And the IPC guidance, again, as you'll also know, has come under significant criticisms. You've told us about a few lessons learned by RHI to improve its ability to respond. One of them is showing you're working and explaining where decisions have come from and how you come to your guidance, and also the fact that you're not using the word recommendations anymore. Criticism was also made of the speed of RHI and the speed at which they were able to respond to the changing circumstances, if you've described it, an evolving situation, and evidence had to be used continually. Is there anything that has been changed or anything that has been considered to allow RHI to respond to things more speedily?
I'm not aware of the criticism around our inability to respond speedily. As I said, we were the only organisation in the UK that was putting these rapid reviews out on a monthly basis. So I think our response to trying to get the evidence out to our stakeholders was done quickly and efficiently. There may have been some criticisms of how we done that, but we certainly were the only organisation to do it and to continue to do it for 25 months. I think the healthcare science team and the National Programme for Guidance and Evidence have learned a lot through the pandemic about, and some of it we've discussed today, about, you know, how you pool resources. We should have been pooling from the UK and having the remit so that it was a UK response to that emergent threat. RHI Scotland are quite fortunate in the resource that we have in HAI, and that is really as a result. In 2002 we had the WART report into a salmonella outbreak in a Glasgow hospital, which had recommendations about putting more resources into infection control, that they shouldn't be a subgroup of public health, that they were a specialty and they should be. And then we had, of course, you'll be aware of the Bailey Leaving inquiry that followed on and the recommendations that came from that. So RHI Scotland probably thought the 4 UK countries was the best resourced and most able to respond in that way. We were the only UK country that was on a daily basis reporting in all the COVID clusters and monitoring that very closely as well. So we did respond rapidly. Maybe there was some areas that people would like to have seen us respond differently or quicker. But I think around the evidence, it would have been beneficial if we had pooled resources within IPC across the 4 UK countries to make that more efficient.
So more efficient, it would be more speedy if there was more collaboration, effectively. Finally, in trying to work out how RHI works and how it fitted into the whole system, I must confess I personally found it quite a challenge. I don't know if other people did, to see where it properly fitted in. And what I was wondering was, would it help RHI if there were clearer governance and reporting structures or supervision, so that it was clear to people looking at it exactly where you fitted, what your status was, who you were reporting to? It's like you said about earlier on when you had the word recommendations and you changed it to guidance because you weren't recommending things. It seems a bit diffuse and woolly. Would governance structures assist you?
So earlier on I was referring to rapid reviews where there is no national or international standard for the methodologies. So we were, if you like, learning as others did during the pandemic, what worked and what didn't feel so comfortable for people when they were reading rapid reviews. I wouldn't like to consider supervision. All our staff are employed because of the experience, skills and qualifications they have, and we kind of monitor that we're doing it. I would rather prefer it as a kind of collaboration. I think we could do wider collaboration so that we're bringing in different skill sets to help develop some of the guidance.
And can I ask what those, if you had ideally someone to bring in to help you to do that, who would it be, what body?
I think that depends on what guidance you're writing. So recently when we've done the transmission-based precautions, we've sought some international experts in aerosol science and infectious disease to go through the research questions that we're setting. And the other literature review that we recently completed was water in the healthcare environment, the risks of water in the healthcare environment, where we saw water and engineering expertise to help write the research questions. So I think it depends on what guidance you're writing.
So it would simply be the ability to be able to access these resources as and when would be the best way to put it.
Yeah, I think it's important as well that RHI have a working group that develop guidance, which, although we publish the final guidance, there are multi-organisational and disciplinary people on the working group, and they also help set the work plan for the year for the evidence, so they're helping prioritise what's important.
Milady, those are my questions.
Thank you very much, Ms Mitchell. Very grateful. That completes the questions for you, Ms Imrie. Actually, no, it doesn't. I have one more, sorry. And it's all to do with the very beginning. You told me about your expertise. You said you qualified. You didn't tell me you qualified as what?
Oh, I was a registered general nurse that qualified originally.
I had guessed that might be the case, but I just wanted to check. Thank you very much for your help.
Thank you.
Very well, 10 o'clock tomorrow, just to alert people who haven't been aware, because I wasn't aware until later, there's the possibility that one of the unions is going to be striking on the London Underground on Thursday. So we just need to make necessary arrangements. Thank you very much.
All eyes.